I think the role of the surgeon is very important in the multidisciplinary team in terms of managing cancer. In particular, when managing older adults with cancer disease, I would say it's probably even more important because surgery is the only treatment which potentially cures cancer at the moment. If we put aside hematological malignancies, that's focusing on solid tumors. And say, for example, for someone like an old adult with cancer, which we think the person is probably not suitable or not fit for chemotherapy, or not, the other way around, not suitable for surgery, let's say not fit for surgery. I doubt if that person would be suitable for chemotherapy. It would be quite tough for that. So therefore, surgical treatment or other forms of local therapies like using radiotherapy and so forth, which is being touched upon at this conference as well, is quite important in managing this group of patients. As in most oncology conferences, we tend to have a huge population of medical oncologists to talk about chemotherapy or different kinds of targeted treatments, which I don't disagree with, and they're important treatments. But we should not forget local therapies such as surgery, such as radiation therapies, which are very important, especially they tend to give the patient less sort of in terms of systemic side effects. I think the key points were where I sort of looked at the literature for the last year. I was unable to find any groundbreaking studies. However, there were emerging randomized controlled trials and some studies starting to focus on geriatric assessments, how to select patients. So the bottom line would be for a surgeon is how best to select the patients. So the best surgeon is someone who knows when not to operate. So can we select the patients that we should not operate or should offer them less radical surgery? That's point number one, I would say most important. The second point would be then, you would then have two groups of patients. One group, you've selected them, that you should operate or offer them some sort of surgery. The other group would be for those that you don't. For the first group, the key point then for the role of a surgeon would be how to optimize their care before, during, and after surgery. That probably fits with my research themes in breast cancer. I look at two things. One is from the biological perspective. So you need to look at the biological reasons to treat certain cancers or not to treat. For example, using breast cancer as an example. Breast cancer could be treated in some patients with hormone-sensitive breast cancer by an anti-hormone treatment, for example, which may not be available in some other solid tumors. That's a biological element. Then the other element is the geriatric element, which fits in very well with the vision of SIOG, is to look at the individual from the geriatric perspective, the geriatric domains, not to say other things like quality of life and patient choice and all these. Try to decide how to select the best patients to have an operation or not. Think about alternatives. And second thing would be for those that you have selected to operate on them, optimize their state so that they can undergo surgery with minimal complications.